Perfect.
All right. Ready?
Yep, go for it.
Hey everyone, I am Dr. Omar Watson, and today I'm going to be presenting on anesthetic considerations for the pediatric patient. As you can see, I'm nicely dressed for my lecture. My dad always told me to wear a shirt and tie. However, in the spirit of the lecture and being in our PJs, I do have on my PJs too. Bam, bam. So, anyways. This is a very important lecture to me. When I first started in dental school, I was actually interested in pediatrics. And then I had my first patient who was like 11, 12-year-old who cried when I was flossing his teeth. And I said, I do not want to do this 100%. However, now that I'm in private practice and I've been practicing for a while, I'm finding that that is a pretty good niche of mine, and about 20% of my patients are pediatric patients, and I tend to do pretty well with them. So I do like that aspect of my practice. So let's get started, shall we? So today we're going to discuss some key points here. We're going to discuss the anatomy and physiology of the pediatric patient. We're going to discuss standards and management considerations for the pediatric patients in oral maxillofacial surgery office. We're also going to discuss some current events, the current media coverage of sedation in dentistry, and the American Academy of Pediatrics and the American Academy of Pediatric Dentistry for Sedation's joint statement on this topic, okay? Disclaimer and acknowledgements, all the clinical pictures in this presentation I obtained consent for. Pictures obtained from the internet are not used to illustrate points, are used to illustrate points of the lecture and not altered in any way. And the information that I'm going to present is evidence-based, but also based on my own anecdotal experience. So, estimated 100 to 250,000 sedations are performed annually a year, and that's on pediatric patients. Common medications that are used in sedations are benzodiazepines, opiates, local anesthetics, nitrous oxide, and others. Mostly, we are finding that this is safe and routine. However, there are other risks that we will discuss in this lecture. The goal is always to mitigate risks and to perform safe treatment on all of our patients, especially our kids. So, pediatric age defined by the American Academy of Pediatrics, American Academy. So, newborn, birth to 1 month of age. This is my son during that time. You can see here, and then this is him as an infant, defined as 1 month to 2 years of age. And then this is him with this wide range here as a child, 2 to 12 years old. This is him at 6, and you can see the dental development there, and age 12, which is actually current with the dental development there, losing his canine, primary canine. And then adolescent, by American standards, actually goes all the way up to 21 years of age. And this is my son utilizing an app showing him at potentially 21 years, handsome young man, but this is fake news. So, but I thought I would put it in the slide. So we know that children are not little adults. There are stark differences in anatomy, physiology, behavioral, and psychological differences. One size fits all does not apply, and we need to be cognizant of these differences for safe practice. So for kids, I mean, we look like giants. Most people who know me know that I'm a little guy, proudly so. However, at that age, that's my son there, I was a giant to him. And we all look like giants to young kids, and offices look big. And so we have to make things look a little smaller to them to make sure that we can manage them safely. Successful treatment is largely based on behavioral management. There we go. And so we're going to talk a lot about that. Expected behavior is a function of cognitive, social, and emotional development, and preoperative assessment is the key to being able to manage these patients. So sometimes they give you cues, sometimes they don't. Got a lot of pictures of my son in here. That's my little buddy. So All right, so one thing that is kind of a model that I use when I see patients is that I always think about it in terms of the psychological differences cognitively. A lot of patients, you know, the example I gave at the beginning of my lecture of having a patient who I was just flossing his teeth at 11 years old and he was crying and screaming. I mean, cognitively, his brain is not developed enough to be able to use logic to get him to relax. There's different methods that, you know, I was able to do even at that time to be able to perform the procedure. But as time has gone on, um, I've really been able to see that when you have a child that's less than 6 years old, often they can't comprehend the need for surgery. Often they have kind of a fictional way of thinking of things and thinking they can wish it away or that they won't have to do it. And it's it's hard. You don't want to spend a lot of time trying to use logic to get a 6-year-old to say, okay, yeah, I'm going to sit and be still and do surgery. Over 6, sometimes you'll be surprised. They can understand, they can express their concerns. It depends on the maturity of the over 6-year-old. You know, rule of thumb, girls tend to mature quicker than boys, but not always the case. And then adolescents, most of the time they can comprehend the planned surgery, and you should absolutely consider involving them in determining the anesthetic treatment plan. So there's a spectrum of emotional differences in behavior, and we hope that all of our patients are cooperative, but things can change, and we should be prepared for that. So you can see this is a picture of a young lady who is very cooperative. Looks like she's gonna have a nice treatment. I always say it's like a massage. It's like, so then you have the apprehensive patient, and you can read it all over her face. And so, you know, what are some strategies that we need to use to approach these patients to perform care safely? And then you have the end of the spectrum, the terrified patient. Of course, I probably shouldn't have wore that mask that day. No, I'm just joking. But you can see some patients, they do see us as scared. They do see us as monsters. And so how do we manage that? You have to keep that in mind. So determining the anesthetic plan for pediatric patients. In my office, in all of our offices as oral maxillofacial surgeons, of course, we perform procedures with local anesthesia, nitrous oxide, and or PO sedation, IV sedation, and general anesthetic when need be. The things that I look at are obviously the age of the patient, prior surgical experience, the duration of the procedure, which is very important. And then the last two, you know, we're concentrating on right now because that's a lot to do with anesthetic involvement of pediatric patients is their level of anxiety and their ability to cooperate. I repeat, their ability to cooperate. That is very important because that is what's going to allow us to keep them safe, and their ability for the parent to cooperate. So that has a lot to do with their psychological assessment. And disclaimer, I'm not a psychologist, but all of us had to take some class in psychology, and by default, we all tend to have to understand some behavioral issues with all of our patients, young and old. So engaging the parents, that's the first thing. You know, I walk in, I'm like, hello, my name is Dr. Watson, shake their hand. I look the kid in the eye, shake their hand, try to connect with them somehow. This is my wife and my daughter when she was younger. This was the first time she went to sleepaway camp, and I was very strong. I did not cry until 2 days later. But anyways, so parents are a very important source of information. It's very important to engage them to get an idea and assessment of that kid's maturity and ability to handle care. If they've had any treatment in the past, how they reacted. You know, I always tell parents, I just met your kid 5 minutes ago. You've known them for however long they've been alive. So I'm going to listen to them for the most part. Don't underestimate good parent and helping to facilitate care. So this is like my daughter again. I actually took out some baby teeth on her. She needed nitrous oxide. She was very much so able to verbalize her concerns to me that she was not going to be able to do it awake. I even offered to have one of my partners, all of my partners I trust, to do it, and she wanted daddy to do it, and so I did it. But she was able to make a decision about her anesthetic plan. And I've had kids younger than her do it awake, which is local anesthesia. So, but it's building trust. So I'm glad she trusts her daddy. Also communicating on their level. Yes, I'm a doctor. Yes, I have a DDS and a medical doctorate. But you know, I'm a kid at heart. Most men are from some respects. So it's a little easy to me to gain rapport with most kids because I find something that I can identify with them. But it's also important to be non-pretentious. Kids, anybody doesn't like somebody who's arrogant, but you know, you don't want to lord over them and make it seem you're this big doctor. You just are a person that is a servant. You're there to help them. You're there to do your job, and you're there to provide care. And that comes with respect, and they will give respect because kids. This cartoon is true. They're not going to trust you when you first come in. Most people don't, but especially kids. Why should they, right? So you have to keep that in mind. So, in the way. Right. So, anxiety, big thing in dentistry, right? But it's also a big thing in any medical profession. 50 to 75% of child patients exhibit significant anxiety. You can see from this picture, this is my daughter and some of her friends, and you think you can read them. You know, the gentleman on the far left is sticking his tongue out. He seems to be silly, but it could be a defense mechanism. He could just be very scared and is trying to stick his tongue out to be silly. The girl right next to him has this straight face. She may seem like she has an attitude, or maybe she's just trying to figure it out. She's trying to figure you out. Then my daughter, you know, I still can't figure her out. But anyways, so the thing is, you always have to think about most kids, 50%, 3/4 of kids are going to have some type of anxiety with a procedure. And you should consider modifying treatment for them, especially kids with psychiatric diagnoses, attention deficit hyperactive disorder, depression, anxiety. Drug abuse is an important thing, and Dr. Wadowski will be talking about that tomorrow. And special needs patients, of course, and others. So in terms of special needs, and a lot of kids in general, you know, special needs, that goes up to adulthood. A special needs patient can be 30, but cognitively they can be 6, right? But they do better in familiar surroundings, so it's important to engage the closest relative or parent or guardian about special needs patients. A lot of times they may have a toy that they're fixated with, or some object, or there's something that they can identify with, some TV show that you can help them get through a procedure. Simple language is important. You know, I always use words like, oh, it's gonna feel like a pinch, or I'll lightly pinch them in the presence of their parent and say, does that hurt? They're like, no, like it's uncomfortable, but it doesn't hurt. And so that's what it's gonna feel like, and they can identify with that. You need to know the patient's coping mechanisms, as I explained. Involve the parents in the pre-op discussion is very, very important. And when we induct and recover the patients, we usually do that in the presence of a toy. And this is, you probably recognize this, but most of the time they come in with a stuffed toy, special needs and young kids. And I always ask them, what is the stuffed animal's name? And 50% of them don't have a name. So I always like joke with them and try to get a name for their stuffed animal if they don't have one. Of course, the last name is always their last name. But for whatever reason, the name always includes bacon. I don't know why. Like bacon brown or something. It's weird. But anyways, that's just my practice. Maybe it's different in yours. So parents in the operatory room, very important. So when I first started, you know, I've been blessed to be a part of Virginia Oral-Facial Surgery. It'll be almost 12 years. Time flies. And when you finish residency, you come with all the knowledge and some experience and things of that nature. But you come into a big practice, and a lot of times you come with staff that is already trained. And a lot of the staff at that time were trained not to let the parents back by all means, never. And I was trained similarly, but the opposite, that you need to listen and see what is going to make that patient and parent more comfortable. And so it was a fight at first, but you know, we got it together. But the advantages of bringing a parent into the operatory room is it decreases the psychological trauma of the parent and patient sometimes, okay? Sometimes it's a smoother induction. It can help as long as you are in control as the provider and the parent helps you. If the parent is trying to be in control, it's not going to work. And of course, we've all experienced that. And sometimes it can go south, but you know, that's part of practicing, right? So disadvantages is it can disrupt the routine, unpredictability of the parent behavior, increased time and cost. And another thing is you don't want that parent to become your patient. You know, I've seen when a parent has almost had a syncope episode, that can be disastrous, right? So, you know, that's very important. Or a parent who has a takeover spirit. They come in and they try to tell the kid exactly how they should do anything. They're not trained in medicine or dentistry. And so they need to understand that they are your help. And it's always okay to cancel a procedure if you don't think you're getting that. So again, children are not little adults, but sometimes they are cray, crazy. For all you people who don't understand, it's a new urban term, cray. But in this particular situation, oh, yes, ma'am, yes, sir, we do have a poll here that we need to do. So if you guys can take the time to do this poll, this will also help you get CE for my lecture. I'm hoping that everybody gets this right. I'm gonna pause so you guys can do that.
They're still voting, so I'll let it run for just a little bit longer.
Okay. Well, the answer is parents in the operating room can sometimes decrease anxiety for both themselves and the child. All right, so moving on. But in oral surgeon's practice, of course, one of the big tricks that we have is that we can sedate a patient. And sometimes children are cray, children require anesthesia, you see. But the biggest thing that we need to think about is what will they see when they go into the operatory? You can see this is one of our operatories. It's big. I mean, it looks big to us. It looks big to them. We have all these equipment, things beeping, and they need to be prepared for that. That's why it's important to gain rapport. You have a mask potentially if you're going to do general anesthesia. Sometimes I bring props into our consultation room to kind of show them little things that they might see, like the tourniquet, and I'll lightly put it on their arm and I will say, oh, we have a little bracelet, it's a little tight, it's only on there for 5 seconds. And then, you know, I'll actually show them the angiocatheter that we might use. And I won't show them close to them, but I'll show it on myself. I won't poke myself, but I'll show them that the catheter is actually plastic, but there's a pinch that's involved with that. And you'll be surprised how many kids feel like they can sit still for that. They can't, then any general. So these are some of the medications that we use in the setup that we use. So engaging the patient, engaging the parent, building trust, and communicating on their level is all important in making sure that we have a fluid transition from the consultation to the treatment area. And again, you want this result, you want success, right? And number one, we want to provide safe care. So this is my little man in one of our local pediatric dentist office when he was a little dude. I think that's their bear. We didn't have that bear, but anyways. Goal is to provide safe care. Sedation is an adjunct to help facilitate this care. All kids don't need sedation. So we can remember that. Assessment will help to guide this decision. So the goal is to reduce anxiety, establish cooperation, ensure comfort, provide amnesia, control pain. And in larger procedures in the operating room, ensure hemodynamic stability is a big part of general anesthesia. So again, these are some of the methods that we use to determine the anesthetic plan. Local anesthesia, nitrous oxide or PO sedation, IV sedation, and general anesthesia. And we talked about different things that we look at to assess these patients' need for which determine anesthetic plan. But importantly, as a surgeon, we're absolutely going to pay even more closer attention to their medical history, their anatomy, and their physiology. So we're going to talk a little bit about this now. So, body habitus, adult versus Charlie Brown, the child. And this may seem kind of funny, but it is true that Charlie Brown represents the typical anatomy for a young child. Another thing, Charlie Brown used to be my idol. I used to be wanted to be called Chuck when I was like in first grade. Anyways, children have a disproportionately large head and a tiny neck relative to their torso. A wide thorax with immature cartilaginous ribs atop a protuberant abdomen. So you can see Charlie Brown definitely represents that big head, small neck, thorax is small, protuberant abdomen. These anatomical things are very important when we're thinking about sedating a patient. We're going to go more in depth about that. And again, like I said, don't judge me, but I didn't want to be Charlie Brown when I was young. That was me when I was young, so that's me imagining myself as Charlie Brown. So the airway for a child is a little different than for an adult. I mean, obviously, we have the same anatomical components, but they're positioned in different areas in the airway, which make the airway more susceptible to obstruction. First, most children have a large and floppy epiglottis. The airway is actually more anterior and cephalad, meaning it's closer to the oral cavity or towards the head. Kids have a shorter neck, and their larynx and glottis and epiglottis is actually at the C4 level, whereas in adults it's at the C6 level. So it's closer to the oral cavity, more opportunity for obstruction. The subglottic region, where the cricoid ring is the narrowest portion of the airway. So subglottic means that it's actually below the vocal cords. So in adults, it's usually the vocal cords are the area where it is where it's more narrow, but in children, it's actually below the vocal cords at the cricoid cartilage area. So you can see this illustration here. Kids, they have more of a funnel-shaped airway, and so anything that's funnel, it's going to bottleneck here, and that's where the cricoid ring is. In adults, it's more of a cylinder shape, and the vocal cords are here in the glottic region of the larynx, and that's the narrowest part in the adult. That's why laryngospasm in adult is, usually happens because that's the narrowest portion. That can happen in kids, but it can also happen below the vocal cords. The trachea and bronchi are more compliant with negative inspiratory pressure, and the ribs are cartilaginous and horizontal. There's less thoracic expansion and more diaphragmatic breathing. The airway and chest wall are susceptible to collapse, more so than an adult. So this is very important when we're doing sedations because there's poor expansion of the lungs, the ribs are soft and underdeveloped, and the chest can cave in under negative inspiratory pressure in young kids. So a little physiology here. Growing children have increased oxygen consumption, but limited physiological reserves. There's increased respiratory rate to compensate for lower lung volumes and less capacity to tolerate hypoxemia. And so basically what that is saying is that kids, when we're breathing our regular tidal volumes, we have gas left in the tank. So we can breathe. And if you ever do yoga, when you say namaste, it's like you want to breathe out and you're actually breathing out a lot of your reserve. Well, kids don't have a lot of reserve. And so they increase their breathing rate to compensate for that. So if they go some time without breathing or without oxygen, they can go down quick. So that's very important to understand that concept. We all know cardiac output equals heart rate times stroke volume. In kids, stroke volume is compromised, their heart is less compliant. These limitations actually decrease the ability to compensate for low blood pressure or fluid overload. So that's another thing to be cognizant of when dealing with pediatric patients. So in dealing with the autonomic nervous system of a child, very important. We know the autonomic nervous system regulates certain bodily processes, including blood pressure, breathing, some liver function, GI function. It works autonomously or automatically. There's two main divisions, the sympathetic and parasympathetic division. The sympathetic division is more stimulatory and the parasympathetic division is more inhibitory. In kids, the parasympathetic division is actually the one that is the most dominant. And immature kids have immature autonomic nervous system and an increased level of they have increased hypoxemia when they're having sedation. So we need to be aware of that. And I'm going to illustrate that on the next slide. So you can see this kid here is crying. This is what we usually see, but physiologically, what we need to understand is that the parasympathetic tone trumps the sympathetic tone. And so if a patient is crying, they have increased secretions. Remember, I told you the negative inspiratory pressure can cause the lungs to collapse more, almost like an asthmatic response in younger kids. Their oxygenation, if they have decreased oxygenation, instead of them having reflex tachycardia to compensate, a lot of times their pulse goes down, so they have bradycardia. Bradycardia causes hypotension, and that can worsen the hypoxemia. And so there can be a wicked cycle that can develop if you're not aware of that. That's why oxygenating a patient, understanding how to use the anesthetic medications to lessen the decreased oxygenation in patient is important. Their neurons are immature, and so they have an increased risk of respiratory depression if they have too much sedative medications. So these are all important things, unless they're Jack, because he's an anomaly. So of course, physiology doesn't apply to him. Now, some of the equipment for pediatrics are similar as they are for adults, but there are specific things that we have in our repertoire that are important for kids during emergencies and also during routine sedation. The most important thing is PAL certification. All the oral surgeons in my practice are PAL certified, which stands for Pediatric Advanced Life Support. We also have correct pediatric sizes for equipment, and very important to have all my kids weighed at the beginning of their consultation, so we can have record of this if we decide to do surgery, and we can decide which medication doses we need if we do IV sedation and or if we do general anesthetic. So most of us are familiar with the Braslow tape. This is the standard in emergency treatment for pediatrics. So in our crash carts, we have this, but it relates to the child's height and weight. It provides the medication dosages, equipment size, and if you need to defibrillate, which voltage you need on the defibrillator. It's designed for kids up to 12 years of age with a weight of about 80 pounds. So literally patients on the ground or on the table, and you use this tape to measure them, and you can determine all these things. It's not necessarily an archaic method, it's the standard, but nowadays you have apps that can do the same thing. And this is an app that I use. It's a pediatric quick reference app and sponsored by the Children's National Medical Center. And so the first page of this looks like this, Children's National Blue Card. And you go in and it gives you different options, situations, medications, equipment, and what you need. And then this next page, you can put in the weight. You can change this to pounds if you like, and put in some of the information, and it will give you a readout of what their heart rate, respiratory rate could be, and any medications that you need to use and whatnot. So, all right, now I don't know how to get rid of this. All right, so oral maxillofacial surgery residency training, usually 4 to 6 years of residency with an MD option. When I trained, I had mandatory MD at Detroit Receiving Hospital and Wayne State School of Medicine. We do at least 5 months of dedicated anesthesia training, serving as an actual anesthesia resident. And we do at least 1 month exclusive to treat pediatric patients. So you can guarantee that that produces a competent surgeon, anesthesia provider. The only people that are trained more in anesthesia are the nurse anesthetists and the anesthesiologists. Even emergency medicine doctors, they literally do about a month and they only learn how to intubate for the most part. So this can make us a target, as we know. So we're going to talk about this a little bit. What is the latest news in the oral and maxillofacial surgery realm? Well, there's been a joint statement on pediatric sedation that went out, and this joint statement was organized by several societies. Number one, the American Society for Anesthesiologists, the Society for Pediatric Anesthesia, the American Society of Dental Anesthesiologists, the Society for Pediatric Sedation, and it's regarding the use of deep sedation or general anesthesia for pediatric dental procedures using the single provider / operator model. So that pretty much defines what myself does as an oral maxillofacial surgeon. So the statement actually suggests that the single provider operator practice model, oral surgery, is incapable of providing skilled help to rescue a child. They suggest the use of another certified anesthesia provider or a second oral surgeon is necessary to manage sedation, monitoring, and rescue. And they tout this as a guideline. So, safe to say, OMFS versus everybody. Shout out to Detroit. That's not where I'm from, but I did train there. All right, so, but what does the evidence state in this? That's very important. You know, we want evidence when we make statements, right? So I did a literature search of the articles that kind of went along with the joint statement. But this is what you see on the news. Children at risk, 4-year-old boy dies after dental procedure in Oakland, State Board. You see this on the news, and so you feel like it's, you know, very prominent or that they have a point, but we're gonna look at what the evidence states. So this article entitled Trends in Death Associated with Pediatric Sedation and General Anesthesia. Basically, this article, they did a medical search of reported deaths from the media, from the media's report. There were certain exclusion criteria that allowed them to provide the anesthesia providers and the deaths associated with them. And in this article, it pretty much showed, pretty much showed in a 30-year period, the deaths per provider by facility type. Most of the deaths were by general dentistry and pediatric dentists, followed by the oral maxillofacial surgeon, reported by the media. In the same article, they showed deaths per provider by age, and the largest deaths that occurred were in 2 to 5-year-olds, and again, that group that it was associated with were the general dentists and pedodontists. And so that was 14 out of 25 patients in the 2 to 5-year-old category in a 30-year period. So the conclusion of this particular article, basically they say that there's more likely a higher percentage of mortality in office settings. So 70% of the deaths, the 44 deaths that they had in this 30-year period occurred in office settings. Dental anesthesia, morbidity and mortality cases are likely underreported because they only looked at media sources, and they proposed a tracking of anesthesia-related adverse outcomes by creating a national database of adverse outcomes to advance patient safety and quality. So another article that was associated with this joint statement was Ethic Grounds, Death After Pediatric Dental Anesthesia, Is it an Avoidable Tragedy? And the conclusions of that article is that there's no mandatory reporting system, and most reports are imperfect forms of information. Most of the reports were media sources or lawsuits, and most of the lawsuits came from dentists, were coming after dentists, oral surgeons, and ENT. They outnumbered orthopedic surgeons, cardiothoracic, and abdominal surgeons. And they did state the reason why is most likely because people accept that there is a bigger risk with abdominal surgery or cardiothoracic surgery or even some orthopedic surgery, because that's a lot of times dealing with trauma. Whereas people feel like things are routine, coming to the dental or the oral surgeons or the ENT office. The last thing they concluded was they basically asked experts to speculate how to improve on quality and safety. So not a whole bunch of real concrete research or evidence about their joint statement here. The last one, long title, but incidents and nature of adverse events during pediatric sedation anesthesia with propofol for procedures outside the operating room. Report from the Pediatric Sedation Research Consortium. So this consortium collected data, collaborative from 35 institutions, and their conclusion was that sedation and anesthesia for procedures outside of the operating room is unlikely to yield serious adverse outcomes. They actually recorded that the incidence of events that have potential to harm and require timely rescue interventions is about 1 per 89 sedations. So that's like 1.1%. So that's pretty much what the evidence states. So what is the American Oral and Maxillofacial Surgery response to all this? Well, basically, my colleagues came up with the statement, and the conclusion was that our profession has 60 years with an unparalleled safety record. The joint statement from the groups that made these allegations focus on a, quote, dedicated monitor and being prepared to meaningfully help in an emergency. The statement did not concern itself with the education, training, and anesthesia resuscitative capabilities of oral maxillofacial surgeons. So they didn't really give evidence of their claim or the training of oral surgeons. And a lot of times, I mean, rightfully so, sometimes oral surgery, we're a dental specialty, so they look at us as dentists, which they should. That's our background training. But still, when you look at the numbers, the morbidity and mortality is not as high as they're touting, and that's even reported. There's no evidence of that. So, in conclusion, when we're dealing or thinking about our pediatric patients and anesthesia, we must perform a thorough preoperative assessment to determine the anesthetic plan, understand the anatomy and physiology to minimize risk, have appropriate equipment, and provide appropriate communication. Also, very important to, know your training and stay up on the latest and practice at your appropriate level of training and comfort. So, and if you're not comfortable, you can send it to any of these great oral maxillofacial surgeons or the little guy here, Dr. Watts. So these are some of my references. All right, any questions?
Thank you, Omar. That was great. Do we have any questions? There was one question I saw here. It was, how about conscious sedation for pediatrics? Any rules for that was the question.
That's a good question. I mean, it depends on your state. You know, I know in Virginia a couple years ago, they were trying to define what light sedation versus moderate sedation is versus deep sedation. And I went to a couple of those meetings, and there's no black or white. There's really gray area for that. But for the most part, they do not recommend, well, they're mandating that you are not to do any deep sedation if you don't have the emergency training for it, in terms of PALS, ACLS, or a certain number of hours that you have trained for that. But a moderate sedation is a patient who is responsive. Like they can respond to commands. Deep sedation is, it may take a lot of provocation to get that patient to respond. There is going to be some airway compromise or decrease. And so if you're giving a patient the correct dose of oral medication, is, the most common ones, it shouldn't cause a lot of airway compromise, and it should be in the light to moderate sedation category. But if you're giving an IV, that's a deep sedation for the most part.
Next question is, do you think the dedicated monitor should be ACLS and PALS trained as well?
I like our current model. Like everybody is PALS and ACLS trained. Our assistants, the nurses in our practice have that training. And I think everybody who is in oral maxillofacial surgeon's office who is doing sedation should have that level of training with patients.
Thank you for that. Next question, can you talk a little bit about local anesthesia? I'm assuming in pediatric patients that are not being put to sleep, do you always do nerve blocks, or is infiltration adequate in most cases?
That's a good question. I remember when I was in dental school, and I was a first year, and I don't remember the lady, but she was a fourth year, and she was a little older student, so she was kind of like a mom to me. And by the time I got to my fourth year, she came back just to say hi and talk, and she was in private practice. And she said, it's hard when you first get out, but you got to understand that as long as you have good anesthesia, you can get through most procedures. So for any pediatric patient, first of all, I can sedate them, but if they're not going to be sedated, I make sure that we have good anesthesia for all the patients, because if you can't get good anesthesia, or you can't get them to understand what they're going to feel, it's going to be a headache. And so if they require a block, then I'm going to give them a block. Infiltrations obviously in the maxillary arch are important, but if I'm doing a lower molar or something like that, even if it's a primary tooth, I tend to want to do a block just to make sure. So, and I do infiltrations as well for those procedures.
Next question, do you ever use oral sedation in cases where the patient cannot be put to sleep, or in situations where nitrous is ineffective?
That's a very good question. So like you kind of learn anecdotally through practice, and my protocol used to be to give oral midazolam and wait a certain period of time, have them taken in the office, wait a period of time, and I don't know, maybe it's what I'm doing, but it does not work most of the time for me. So most patients, I feel like if I can do things on the front end to gain their trust, and sometimes I still use the oral midazolam, but not as the primary method, mostly for a procedure. Either they're going to stay awake and do nitrous with oral midazolam, or if I can get an IV in, then I give them a little medication to get them through, and we do it that way. Or the final option would be general anesthesia. So I don't routinely use oral medication for younger, I would say 12 and under, unless I'm giving it to them as an adjunct with something else.
Agree with that. Are there any other questions for Omar?
Hi, Jenny Wheeler.
Okay, here's a couple other questions. What's the maximum of anesthesia that you can give a child? Will this depend on weight, etc.?
What's the maximum anesthesia you can give a child depending on weight?
No, I mean, I think the question is, will this depend on weight?
Yes, it depends on weight. But so anecdotally, I follow that rule, but I follow it a little differently because people people can metabolize drugs differently. I mean, you don't know, you're not inside that person's body. So yeah, you do go by the weight rule, especially with kids. But I don't start any kid or adult up off at a high dose. I start at probably half the dose of what may be recommended, and I just titer it from there to see how they respond, and I give them time because, especially with kids, when you're sedating them, they go through an excitation stage, just like when they're going to sleep and they get real silly, and then all of a sudden, boom, they drop. That's how it is in sedation. So if you're giving them anesthesia and they're going crazy, and you start giving them more, you can snow them. So you have to be patient. You have to understand which phases of anesthesia that they're going through.
Next question from Dr. Campbell. What percentage of your pediatric cases do you do with protected airways, such as LMAs and or endotracheal tubes?
That's a good question. So I ran the numbers on how many pediatric patients 12 and under that I'm doing with true sedations. And I found that I was doing the most in the practice. And it only represents probably 20% of my total patient load. And I would say out of that, probably 10 or less percent we're doing with probably 10 to 15% with LMAs, endotracheal. And those are patients that are usually 7 and under, okay? So a lot of my patients, probably 90% of them are above that. They're, if they're pediatrics, they're between 8 and 12 of those, 8 and 12 years of age for the sedations, true sedations that I'm doing. And so I'm really doing those LMA or endotracheal tube patients for really young patients that don't have the cognitive ability to take an IV, or just medically and anatomically, I don't think that the single anesthesia surgeon model is appropriate for.
I think it's also worth mentioning that we do have an accredited surgery center where we do these cases under general anesthesia with LMAs and intubation when needed. So
Yep.
in most vast majority of these cases do not have to go to the hospital to be done.
Yep.
Question from Neil. Sometimes the parents are more scared than the patient. How do you counsel parents who are nervous about their kids going to sleep?
Well, that's a very good question. I mean, see, you have to find out what they're nervous about specifically. So for example, like I'll ask parents and I'll ask kids, so what makes you nervous? Because it seems obvious that someone will be scared about the actual dental procedure or the oral surgical procedure, taking out a tooth, the cutting. Am I going to have pain? What's it going to be like? But some people are afraid of the anesthesia specifically, the loss of control, not being aware. Are they going to say something crazy when they wake up? And so first I find out exactly what makes them nervous, and then I go along the lines to explain them with evidence-based why they shouldn't be or why they should. And if I can't get them to feel comfortable, then I tell them they should stay awake, or I give them another option. So it just really depends on what's making them nervous.
Perfect. Well, I think that's all we have for questions. Great job, Omar. If there are no other questions, I think that wraps it up for today, unless you have anything else you want to say, Omar.
Nope, I just want to say everybody stay safe. I'm a guy that gets energy off personal contact, so it's kind of weird to me, but I hope everybody enjoyed our lectures, and we're happy to do some more as the time goes by to give everybody their professional credits and to do our part as providers. So